Today we're going to be talking about skin cancer, and we will go into the common types of skin cancer, how to identify them, and then treatment options and prevention. And during this presentation, I do have some pictures of various skin cancers, which can sometimes be a little bit graphic. So I'll have a warning slide before that comes up, just in case, if you don't want to see the pictures, then you can just look away, cover your eyes at that point. And they won't last too long, but there'll be a little heads up. So there's basically three common types of skin cancer: basal cell carcinoma, squamous cell carcinoma, and melanoma. And skin cancer is very common. It is estimated to develop in about 1 of every 5 people. The basal and squamous cell carcinomas are definitely more common and not even included in cancer estimates in terms of new cases per year. But melanoma does make it into the top 10 for both men and women. In men, it's the 5th most common cancer, and in women, the 6th most common, but not in the most common causes of cancer-related death. So we'll start with basal cell carcinoma. This is typically a skin cancer that's very common in white populations, very uncommon in darker skinned people, and has a higher incidence in women as well. In places that are closer to the equator, including California, there's more incidence of basal cell carcinomas just from that UV exposure compared to other places like the Midwest or things like that. And the incidence increases with age, kind of that cumulative sun exposure over time. So people that are between the ages of 55 and 75 have 100-fold higher incidence compared to those who are under 20. This basal cell carcinoma tends to be very highly curable. It's usually a localized problem and generally very slow growing. But if untreated in the local area, it can cause destruction of cartilage or other tissues there. And it's very rare for it to actually spread anywhere else in the body, whether that's lymph nodes or another organ in the body. And typically with cancers, that spread is what would be life-limiting. So basal cell carcinomas are not usually something that's going to be fatal. It's just more of a local issue to manage. There are 2 common types of basal cell carcinoma: nodular and superficial type. And so we're going to have some images here. So the nodular type is the most common. It's about 80% of cases, and you typically see this like pearly kind of raised border, kind of a smooth, shiny border around. Sometimes there's these little blood vessels in it called telangiectasias, and then a central ulceration. This one, bigger ulceration here, not quite as much border, but still, this one's really more on the left, is a more classic appearance. And if it happens somewhere like the ear, it can start to cause destruction of the cartilage locally, kind of eating away there. And then the superficial type is just more like a red or pink area with some patches or bumps, and that's a little bit less common. For squamous cell carcinoma, similarly to the basal cell carcinomas, generally more common in fair-skinned people, but can also develop in darker-skinned people. And usually in fair-skinned people, it's developing in areas of sun exposure. In darker-skinned people, it tends to be more on the lower legs or anal genital regions, like not really areas that typically really receive a lot of sun exposure, and can be associated with chronic scars or inflammation that's happening. And that's usually about 20 to 40% of the cases in darker skinned people. There is a squamous cell carcinoma that forms in relationship to a scar. But squamous cell, like basal cell, generally very highly curable, usually localized, although squamous cell does have a little bit higher risk to spread to either lymph nodes or distant sites in about 1 to 5% of cases. And squamous cell can also be associated sometimes with pain or itching, and sometimes there can be symptoms like some tingling or numbness that can happen in an area if it's starting to invade into or cause problems for local nerves in that area. And similarly, if it goes deeper in, it can also cause weakness issues if it affects nerves that control motor function. With squamous cell carcinoma, there's also two common types, well differentiated, meaning a little bit less aggressive, kind of slower growing, more well behaved, and poorly differentiated, which would be a more aggressive type. So again, we're going to see some images here. The well differentiated lesions tend to have this more kind of scaly, like a scaly bump sort of appearance, or a plaque, which is sort of a little bit larger raised area. And then the poorly differentiated lesions tend to have more of like an ulcerated or sort of a fleshy appearance to them. And for both the basal cells and the squamous cells, really the biggest risk factor is exposure to sun, to UV radiation. And it's related to kind of cumulative or kind of additive exposure over your lifetime. Other causes, although less common, would be chronic exposure to arsenic. Radiation therapy can also put you at risk for skin cancers. If you're on long-term immunosuppressive therapy as well, like if you've had some sort of an organ transplant, and genetic factors and inherited disorders also can play a role. The next type that we'll talk about here is melanoma. And the melanoma incidence has been increasing over time from 2001 to 2015. But it's been found to actually be decreasing in younger adults and adolescents over a similar time period. Possibly it's thought that may be related to kind of better education in terms of preventing sun exposure, wearing sunscreen, and just being more cautious about sunburns. But in 2019 in the United States, it was certainly most prevalent in the white population, still relatively rare, but 27 per 100,000 people would have melanoma. And then in the Hispanic population, less common, 5 per 100,000, and then really quite rare for Blacks and Asian Pacific Islanders. Melanoma tends to be the most serious form of skin cancer. It definitely has a very high risk for spreading to lymph nodes or distant sites. And it's just absolutely crucial to be able to diagnose it and treat it early. And if it's treated very early, it can have a very good prognosis. It's when it starts to get bigger or grow more deeply into the skin that risk of it going somewhere else increases. Similarly to the other carcinomas, melanoma again is related to UV radiation from the sun. With melanoma, it's about kind of intense sun exposure, so having sunburns. There's a twofold higher risk in people that have had at least 5 major sunburns in childhood or early adolescence. So really wearing sunscreen and protecting against that can significantly reduce the risk of melanoma. And in addition to that, there's other kind of less common causes. About 10% of cases are genetic or hereditary. And then anyone that's had a non-melanoma skin cancer, basal cell or squamous cell, is at higher risk of having a melanoma, just because they have similar risk factors, both of them, associated with sun exposure. And similarly, immunosuppression can also increase the risk of developing a melanoma. So some images of melanoma here. There's basically 4 major subtypes. Superficial spreading, which you can see in the top left corner. then the nodular melanoma, lentigo maligna, bottom left. That one's actually not an invasive melanoma yet. It's more kind of early stage for melanoma. So good to catch it at that point. And then acral lentiginous. So that's a melanoma that would form on like the sole of the foot. And with melanomas, there's basically a rule called ABCDE to try and help identify these lesions. And so there's 5 characteristics that you should be on the lookout in terms of finding them on yourself. So A is for asymmetry. So if the spot is kind of different on one side compared to the other, so you can kind of see that here in the upper left, that it's not just like a round circle that looks the same on both sides, but looks a little different comparing one side to the other. B is for borders. So having irregular borders, you can see again with this lesion that it's sort of kind of bumpy on the border. It's not just a smooth line, and similarly in this one as well. C is for color, so having a dark black lesion or having multiple colors in a skin spot. So you can see here there's like a darker area here and then lighter here, over here in the top right. Again, there's an area that's lighter and another area that has darker areas. And then this is also an example down in the bottom right of just a melanoma that forms in kind of the nail bed, and you can see a dark line that begins to grow out through the nail. And then D is for diameter. So any lesion that's getting large, typically something that's larger than 6 millimeters, which is about the size of a pencil eraser. So just something to keep in mind if you're looking at any of your spots. And then E, I think this is really, one of the biggest ones, anything that's evolving over time. So changing in size, growing larger, or the color pattern changes on it, that there's like an area that becomes lighter or potentially darker. But anything that's changing really should be checked out. And there's also some common benign skin lesions that you may see on your body. So skin tags, just kind of little fleshy tags, nothing to worry about. Cherry angiomas, relatively common, little very bright red moles that tend to, they do grow over time slowly, but really nothing to be concerned about. And seborrheic keratoses, these are kind of sort of stuck on lesions. Some people might call them like barnacles. They're sort of something that can happen over time with aging, and can also be related to sun exposure, but not a malignancy, not a cancer, and not anything to worry about. They can kind of grow with time, but if you had a spot that you thought might be this, or you're just concerned about it because it's changing, then, good to see your dermatologist or your family doctor to have it looked at and see if there's anything of concern there. So when to see your doctor? If a lesion or a mole is growing or changing, it can be a spot that's been there for many years and then suddenly starts to change. If you do notice that, go in, have it checked out. If you have a spot that's, you notice kind of it bleeds a little and then it scabs over, and then the scab comes off and it bleeds again, and it just doesn't seem to be healing, that's concerning for a skin cancer. So that would be another reason to go in and get checked out. And then certainly any of those ABCDE features. So treatment options for these skin cancers. For basal and squamous cell carcinomas, the treatment options are similar. And the two main things would be surgery and radiation. And so surgery treatment options, sometimes it's a little bit larger surgery that's done, just basically cutting out the skin cancer there. And other times there's an option to do something called Mohs surgery, which is where the dermatologist goes in and they cut out the initial area that they think is involved. And then they take a look at that under the microscope and see if there's any cancer cells that are at the edge where they cut. And then if there are, they do another cut in that area. and then again, examine it under a microscope, and then can keep going down in terms of layers with the ultimate goal of being removing everything, but with, you know, minimizing the area that has surgery to as small as possible. In terms of radiation, which is the other standard treatment option, and tends to be similarly effective to surgery. It's maybe a couple of percentage points less likely to get rid of a spot in an area, but they're pretty close. And so radiation, typical treatment options would be either with electrons, which is a form of radiation that delivers radiation very superficially, so closer to the skin and not going like deep into the body, which makes a lot of sense for skin cancers. Or another option, which is not as widely available. We do have it available I'm in the West Hills office of City of Hope, and also Santa Clarita. And in Santa Clarita, we have also this option of electronic surface brachytherapy, or ZOFT, which is what you can see in the bottom corner here. There's basically an actual applicator that's applied directly on the skin at the site of the tumor. And then it delivers its radiation very superficially to a very, very small area there. In some cases, if a skin cancer is much more advanced, it's much larger, it's growing deeper, or there are lymph nodes involved, then we might treat with something called photons, which is basically X-rays. Just a different form of radiation that allows us to treat deeper and really cover that whole area. Generally, if there's lymph nodes involved, there would be surgery in addition to radiation. And if it's a larger skin cancer, sometimes surgery happens first and then we do radiation afterwards. But sometimes we treat with just radiation alone as well. And the picture on the bottom right here, these are just different kind of what we call cutouts, electron cutouts. So basically, when we're planning radiation to a spot on the skin, we draw out that spot on the skin and then a little bit of margin around it, and we design a radiation field that just treats that little area. And then electrons are delivered by this machine that's up in the top right. It's called the linear accelerator. So basically, just laying on this table here, and then the machine moves around to find the correct angle to deliver the radiation. With electrons, we're usually just coming in from one direction, and then the treatment is just a few minutes. But it's usually a daily treatment over a few weeks, and depending on the tumor size and everything, sometimes that varies a little bit. It could be anything from 2 weeks to up to 6 weeks, just depends. And so how does the radiation work? Basically, either the electrons or the X-rays that come out of the machine penetrate into the body. They're the same kind of X-rays as would be used for diagnostic imaging, like a CT scan or a chest X-ray. They're just very much higher energy and more planned in where we are treating, where we plan for them to go. And so the radiation causes damage to the genetic material inside cells, the DNA, and it can do that either directly or by creating oxidants. So all of these foods and things out there that are antioxidant are usually scavengers trying to get rid of oxidants in the body. But with radiation, we actually locally want to create those because they can cause that DNA damage. And then in cancer cells, the cancer cells don't have good mechanisms to repair that type of damage. And so as the radiation causes that for them, as they try to divide and grow, then the radiation kills them off. It doesn't really work by like burning or physically like with heat or something like that. It's really this damage on a microscopic, a genetic level. But the normal cells, we really deal with this damage all the time. So it's the same kind of damage that can be caused by like UV from the sun, chemicals in our environment, even just spontaneously it can happen as our cells are dividing and growing. And so our normal cells have really good mechanisms to repair that type of damage because they're constantly searching for it, looking for it, and trying to eliminate it. So the the radiation can, in the local area, affect both normal cells and cancer cells, but ultimately aims to kill off those cancer cells because they can't repair that damage. And then the normal cells might be a little bit affected and have some inflammation, but then ultimately recover. And then I just have a few examples of some patients that I've treated with various forms of radiation. So those are coming here. So this was a squamous cell carcinoma of the hand. You can see it has a little bit of that kind of scaly appearance here, and that was treated with electrons. And this is maybe 6 months out from treatment. It does take a while for radiation to work. So after we deliver the treatment, it keeps working and things keep shrinking and kind of flattening over time. But you can see it's pretty much all flattened out there. This was someone with a basal cell carcinoma of the ear. So that was starting to eat away at the cartilage and go a little deeper. And there's actually another basal cell carcinoma up here on the cheek. And so I treated both of those, and essentially has disappeared in that area. He still has this cartilage deformity, so that doesn't really reform or regrow, but the radiation doesn't so much change kind of what was still there. In this case, this was a basal cell carcinoma that had been partially treated with some topical agents, as there are some topical chemotherapies that can sometimes be used for basal cells, although they do have a little bit higher risk of coming back with those. But in this case, this central spot responded to those creams and went away, and then there were a couple of persistent areas, and so she was actually treated with the Zoft brachytherapy. You can see those have been resolved. This gentleman had a basal cell carcinoma right near his eye here, and certainly, you know, a surgery in this area would be challenging, and he is also older, so there's a lot of times some concern with doing a surgical intervention for someone that's a little bit older and has other medical problems, things like that. So I treated him with electrons, and you can see it essentially just kind of went away, resolved and closed up and healed. And then this one, this gentleman had a squamous cell carcinoma. You can see it has that poorly differentiated look here, but also some scaling. And over a pretty large area, to do a surgery on this, you have to resect a pretty big area and then probably need like some sort of skin graft to close it. And, you know, it's a pretty big surgery to do, but he actually responded quite well to the radiation, and it just kind of flattened out and went away. As I mentioned, for basal cell carcinoma, there are a couple of other options, including the topical therapies. Sometimes if it's a very small lesion, they can just freeze it off with cryotherapy. If the basal cell is more extensive and it would be hard to treat it in a radiation field or do surgery on it, sometimes there's this hedgehog pathway inhibitor that's a systemic therapy that can also be an option. For squamous cell carcinoma, as I mentioned before, in some cases that are more extensive, we might require surgery and then radiation, or if a surgery is done and they can't clear that margin, so if they're cutting and there's still tumor cells right where the cut was made, then it's possible, if not likely, that there are cancer cells left behind in that area. So a lot of times we'll do radiation then to just kill off any of those microscopic cells that are left. And immunotherapy is becoming more of an option for many cancers, but also for squamous cell carcinoma of the skin, particularly in cases that are really extensive or are already metastatic, meaning they've already spread to other areas of the body. And so the way that immunotherapy works is it basically, the agents we have available essentially take the brakes off of our own immune system. So in our immune cells, T cells are one of the types of immune cells that we have in our body, and they have a built-in normal brake on the system called CTLA-4. So one of the immunotherapy agents will basically block that brake on the system. So kind of revving up our own immune system to fight the cancer. And then the other pretty common type of immunotherapy that's out there are PD-L1 inhibitors. And so cancer cells also produce something that basically puts the brakes on our immune system. And so we have antibodies that can block that and thereby not allow the cancer cell to evade the immune system. And these are actually, immunotherapy is a big treatment modality in the area of melanoma. It's been a big game changer for that diagnosis, because it used to be if you had melanoma that went to the lymph nodes or spread somewhere else in the body, lifespan was not really that long and there weren't really good treatment options. But now with immunotherapy, we can see some really durable responses. Even you could potentially call it cure, which we don't usually say about a metastatic cancer. But in some limited cases, immunotherapy can be really effective, especially for melanoma. And then we're going to talk about skin cancer prevention. So the U.S. Preventative Task Force, which provides a lot of recommendations in terms of screening, like how often to get mammograms or pap smears or things like that. For skin cancer, they actually say there's insufficient evidence to assess the balance between the risks and benefits of doing routine skin checks by a clinician or a dermatologist. That said, the American Dermatological Association does not have a specific recommendation that you should get, a mole check every year or more frequently. But if you do have a prior cancer, certainly you should be continuing to get skin checks and monitoring for any additional cancers that may show up, because you would be at higher risk for having additional ones. But the American Dermatological Association does have sort of a campaign in terms of detecting cancers and preventing cancers, that it's more kind of education in terms of keeping an eye out for problematic skin lesions. So they call it spot skin cancer. And basically that involves what to look for in terms of identifying a melanoma, which we had talked about, the ABCDE. And then also doing really thorough exam on yourself in terms of a skin check. And sometimes that may require having another person as well to kind of look in areas that you can't see, or using a mirror to check backs of your legs, checking upper arms and bottoms of your feet and back of your neck, which I think would probably be pretty challenging doing with a mirror. If you had someone else to take a look there, it might be helpful, but that's not always the case. Sometimes we just have ourselves. And sometimes, if this was really a challenge for you to be able to see areas, certain areas, then maybe in that case, it might make a lot of sense to go ahead and have, a mole check with a dermatologist, just to make sure you're not missing any areas. They also say to check your back and the buttocks. So just really covering all skin areas. And then if you notice any spots, they provide kind of a chart to go ahead and write those down and note the size of them, the color, and then so you can, and a little, you can mark on the body here where they were, so that you can just keep track of them. And if anything was changing over time, again, going in to see your doctor. Or if you just had one that you were particularly suspicious of, not sure, again, very reasonable to go have it checked out. In terms of prevention, otherwise, the recommendations are basically related to staying safe with the sun. So sun rays are strongest between 10 and 2. And per dermatology, if your shadow is shorter than you, then you should be seeking shade, especially in Southern California. And then wearing protective clothing to help prevent sun exposure. So long sleeve shirts, pants, long skirts, just a couple of things that are important to note. A wet t-shirt is actually less protective than a dry one. It doesn't really offer much protection at all. So people that are swimming with a t-shirt, once it gets wet, not really very helpful. But if you have a dark one, a little bit better than a light one. And the typical t-shirt provides about an SPF of about 15. But good to wear a hat with a wide brim, protect your face, and sunglasses that block out both UVA and UVB. For sunscreen choice, it should be at least SPF 50 per the Dermatological Association, and something that blocks both UVA and UVB. The SPF 30 will block out about 97% of UV. As you get higher in SPF, like let's say 50 is not really, you know, almost twice as good as 30, because with the curve, you can see it's already blocking out about 97% with 30. So if you're at 50, you're probably getting, I don't know, 98 or 99, but it's not like a whole lot better. So just at least 30. You should be reapplying every 2 hours after swimming or sweating, even though they're water resistant, they don't, you know, stay on entirely, and even on cloudy days, because the sun UV can still come through. And then have extra caution with if you're out on the water, in a boat, or on the snow, or on sand, because all of those can reflect the light back at you, and you can get more than you think you're getting in terms of exposure. Vitamin D, they recommend from the American Dermatological Association to get it through your diet, or you could consider supplements if you're not getting good levels, but not specifically sunbathing for that purpose, and avoid tanning beds, because that's just additional UV exposure. And a couple additional thoughts on cancer prevention. So limiting alcohol intake, certainly alcohol is significantly associated with quite a few cancers, as well as smoking. If you can avoid that or stop that, although sometimes easier said than done. Controlling your weight, very important, especially women after menopause. There's an increased risk of breast cancer with weight gain after menopause. So trying to do that either with diet or physical activity. There have been studies looking at exercise, and that's really one of the great things that you can do if you're physically capable. Having at least 2.5 hours of moderate exercise per week decreases the risk of about 8 different cancers. So really an important thing to incorporate into your daily routines. And then there's other benefits to exercise as well. So it helps to control weight. It can help combat a lot of different conditions, including diabetes and high blood pressure, improve mood, boost your energy. So a lot of benefits from exercise. It's really one of the main things that you can do for yourself. And then a couple of points on diet. So maintaining a healthy weight is key, and just doing that through a healthy, balanced diet. There's a lot of information out there kind of suggesting that sugar causes cancer and it must be avoided. And I have a lot of cancer patients that come in saying they've completely cut sugar out of their diet. But ultimately, sugar doesn't really cause cancer. Cancer uses sugar as a food source, but it would use whatever is available as a food source. But certainly eating a lot of sugar can cause excess weight gain, sort of empty calories. So for that reason, you know, good to everything in moderation. And then the other thing that's relatively common out there, alkaline water, as a way to prevent cancer, because it's thought cancer likes an acidic environment. And so if you drink alkaline water, like that'll kill off the cancer, but not really. Not so, because the cancer can have an acidic environment just because it's growing quickly and it's outgrowing its blood supply, and that leads to that acidic environment. But if you're drinking alkaline water, it's not really getting out to those areas of the body, because your body uses more breathing and also some regulation of electrolytes in the body with the kidneys. And those are the main ways that it manages acid base. It doesn't usually do it through the digestive system. So you're probably just drinking expensive water if you're drinking alkaline water. And that's about it. So take any questions. Thanks so much for your attention. I'm just gonna look for that. Is zinc sunscreen better? Not particularly that I know of. I didn't come across that in terms of recommendations from dermatology. But I think just really aiming for that SPF of 30 for that. Can the effects of radiation causing cancer show up years later? Yes, they certainly can. So with radiation, the risk of having what's called a secondary malignancy or a cancer that's caused by radiation is generally very rare. It's usually much less than 1% risk. And that's a risk that happens over 10, 15, 20 years later. So it takes a long time for that to show up. All right, we have another one. Freezing or chemical/localized treatment seems less dangerous than radiation. How effective are these? They can be very effective for early lesions. So I think those are very valid options in terms of treatment. But if it's something that's larger or kind of growing more deeply, then it just may not be completely treated with those types of modalities. Certainly, if you can avoid a treatment with radiation and adequately treat something with freezing, absolutely, we go for that. But just as it gets a little bit bigger, that it may not be effective, or you might have something that comes back after that treatment that then needs to be addressed in another way. How effective is fluorouracil on benign lesions to help prevent basal cell and squamous cell? Good question. I think it can be helpful with some of the like the precancerous lesions like actinic keratosis. I mean, probably dermatology would be able to answer that one better in terms of how effective that is, but that I'm pretty sure that's you know, a good option to try and control those lesions and prevent them from developing into a skin cancer. Is increased number of moles any concern? Not particularly, not just in general, having a lot of moles or freckles or kind of skin lesions doesn't necessarily put you at higher risk for a cancer forming, but good to keep track of what the ones that are there. Aren't there certain areas of skin where melanoma commonly shows up? Yes, generally it's in sun exposed areas because it's related to that sun exposure risk. But sometimes it's not. Sometimes it shows up on other areas like the soles of the feet, which are typically not exposed to sun. Sometimes it shows up even in non-skin areas. It can show up like in the mucous membranes inside the mouth or inside the vagina. But the most common area for it to show up would be in a sun exposed area. Is radiation offered to the affected area only? Yes. Generally that would be the case, especially for a small localized skin lesion or tumor. We would just treat that area plus like a little margin around it. So in terms of radiation exposure for risk of additional malignancies, it's really related to, you know, that area that we're treating. But sometimes we do treat larger areas with radiation. So particularly if there was a large cancer, let's say involving the cheek that had gone to the lymph nodes, in that case, after the surgery, we're treating not only the area where the initial skin cancer was, but also the lymph node areas of the neck. So in that case, we treat, you know, a larger area, but we don't treat any areas like preventatively. They're really areas that we think harbor microscopic disease that we're killing off with the radiation. Is there any topical treatment to reduce or lighten moles so that we can more easily see new moles show up? You know, I don't know. That might be a good question for dermatology. I think they do have some various creams and things that they usually use to lighten like scars and things like that, but I don't know if they also have similar treatments that might work for moles. But maybe something worth worth asking next time if you have an appointment with dermatology. Interesting thought. Do you have particular brands of sunscreen that you recommend? Not specifically. I mean, there's some that have more like parabens in them or not. And I have ones that I like just based on consistency, but I think, you know, as long as it has a good SPF, then any brand you like is fine. Any particular food you would recommend to ward off skin cancer, particularly melanoma? Not specifically. So there's a lot of things out there. Some people, I mean, are eating a lot of antioxidants or things like that, which may be helpful, but the data constantly changes in regards to like which foods are helpful and which are not. So I don't have specific recommendations for particular foods, but I think just in general, eating a healthy, balanced diet. I tend to try to go more an organic route just because trying to avoid kind of pesticides and chemicals and things, which may have a role, but you know, not entirely clear. But I think in general, not a specific food that you need to eat or avoid, just trying to have a good, healthy, balanced diet. Moles inside the mouth, are they normal for aging? Interesting question. I don't think so. I don't know if it might be not necessarily a mole, but some other sort of lesion. But if there's something that's kind of developing inside the mouth, probably good to have that checked out. There's some concern chemical sunscreens are hormone disruptors as well as bad for the environment. What do you think? I think there's definitely some concern that the chemical sunscreens are causing problems for the coral reefs and things like that. And they may be problems in terms of the chemicals that are in them and what we're absorbing into our skin. And we don't entirely know as of yet, I think. And for that reason, you know, it might make more sense to just try to do protective clothing, you know, the longer sleeves, or, you know, if you're going to be in the pool, there's those shirts that have the long sleeves that are like for surfers that provide, you know, good sun protection. They're like SPF 50 or 30, something like that. And in that case, you can avoid, you know, putting on the sunscreen altogether, which is something that I do a lot of the times, or, you know, wearing hats, just, you know, staying out of the sun if you can. But I think, yeah, I have some concern with chemicals in sunscreens, but I think if you're kind of in a situation where you don't have that protective clothing, but you're going to be out in the sun, probably better to have that sun protection, which we know is important for the skin cancer versus not, and just maybe limit, you know, those times that you're doing it, not do it, you know, constantly. Is a spray tan safe? Yeah, it should be relatively safe. I think the Dermatology Association actually recommends that as an option or an alternative to doing tanning beds, to just do like a spray tan. So definitely an option. Are there any creams used over a long period applied to the skin that can cause skin cancer? Not specifically that I know of. Some creams, moisturizing creams, have parabens, and there's sort of a questionable link between parabens and breast cancer. In some studies, they've found parabens like in breast cancer cells, but it's not really clear that they actually caused it versus were just there. So that might be something to consider avoiding in your creams, is just the preservatives, the parabens. Should all 5 A, B, C, D, E be present for it to be considered cancerous? No, not necessarily. I think any of those concerning characteristics, if it was the color or the borders, kind of any one of those, if you felt like that was there, then you should go have a dermatologist look at it. Are there any risks to having phototherapy? If it's UV phototherapy, which sometimes is used for certain conditions, there may be some risk with that, but then you always have to weigh kind of the benefit of the therapy versus that small potential risk. But it may, if you're having UV exposure, then that can increase the risk for skin cancers there.
All right, it looks like we might be out of questions. Thank you so much, Dr. Gomez, for being here with us today. It has been such a pleasure to have you. It looks like we have, just some thank yous. That it was a wonderful webinar. Thank you, Dr. Gomez. There's one last question if you want to take a moment.
Sure. If there's a family history of melanoma, is there something else to watch for? Good question. Melanoma, I'm not entirely sure. I would have to look that one up, but it could be associated with like a cancer syndrome versus just melanoma in itself. So if there's really a strong family history of that, then that could be suggestive of it being genetic, and then it may, make sense if you have a personal history, or if you have a diagnosis of melanoma and you have multiple relatives that have had melanoma, to see a genetic counselor. So maybe talking to your surgeon or oncologist or whoever your main treatment team is, to see if maybe you can meet with a genetic counselor and talk about if there are other things that you should be screening for or looking out for as well. It's a good one.
Yeah.
Well, thank you so much for having me. Thanks to everyone for attending.
You're welcome. Thank you again. Have a wonderful day.